Hello, my name is Phil Pereira, and I'm the Emergency Ultrasound Coordinator at the New York Presbyterian Hospital in New York City. And welcome to Soundbites Cases. In this Soundbites module, entitled Part 2 of Bedside Ultrasound of the Aorta, we'll look further at the spectrum of disease caused by aortic aneurysms. Hopefully you've joined me first for Part 1 of Bedside Ultrasound of the Aorta and know how to perform the exam of the structure as well as how to interpret images of the normal aorta. In this module, we'll review the definitions and anatomy of the abdominal aortic aneurysm subtypes that you may see at the bedside of a patient in the emergency department, and we'll look at a number of ultrasound images demonstrating an abdominal aortic aneurysm. We'll then conclude with a discussion of the potential pitfalls in bedside imaging of an abdominal aortic aneurysm. Let's review some definitions of abdominal aortic aneurysms. For our purposes in the emergency department, an abdominal aortic aneurysm is going to be defined as an aorta that's greater than 3 centimeters in diameter. Now, rupture of an abdominal aortic aneurysm is definitely more common with aneurysms greater than 5 centimeters, but it's well known that aneurysms that are between 3 to 5 centimeters may be symptomatic in patients presenting to the ED. Now, it's in the location below the renal arteries, the infrarenal location of the aorta, that the majority of AAAs exist, and thus we must look carefully at this part of the aorta on bedside examination. This is an illustration showing the types of aortic aneurysms that may present to your emergency department. Now, fusiform aneurysms are definitely the more common type, as shown in the two pictures to the left, and saccular, as shown in the picture to the right, is the less common type. Let's take a closer look at the fusiform aneurysms to the left. And here we see that a fusiform aneurysm is defined as a diffuse dilatation of the abdominal aortic wall. As shown in the picture to the left, we can see that we have a diffuse dilatation of the abdominal aortic wall infrarenally located, or right below the level of the takeoff of the renal arteries. We can see in the picture in the middle that these fusiform aneurysms may extend from the abdominal aorta down into the iliac artery. In this picture, we see extension down into the right iliac artery. Now let's take a look at the saccular aneurysm as shown in the picture to the right. And notice here that it's defined as a localized outpouching of the abdominal aortic wall. Now, these saccular aneurysms are going to be much rarer than the fusiform aneurysms, which will be more commonly encountered in the emergency department. But remember that the definition of a AAA is going to be defined as an abdominal aortic aneurysm greater than 3 centimeters in diameter. This illustration demonstrates that there are pitfalls in measuring the aorta in a long axis orientation, and that a better orientation is to place the probe in the short axis configuration to get the best evaluation of the diameter of the lumen of the aorta. Let's take a look at the images here towards the left, the long axis orientations of the probe onto the aorta. In probe position 1, we can see the probe positioned along the long axis of the aorta, but notice that it's slightly over towards the side. Thus, we have a side slice, and we're incorrectly measuring the diameter of the abdominal aorta, and we're getting a less than true normal value. As shown in probe position 2, by moving the probe into the middle slice, we can get a correct diameter, but you must be sure that the probe is positioned towards the midpoint of the aorta, and this can be somewhat difficult in the long axis orientation. Thus, most authorities would recommend that the short axis configuration is the best way to truly get a sense of the diameter of the aorta. Let's look at probe position 3 all the way towards the right of the image here. And what we can see here is that the probe is positioned in a short axis orientation across the lumen of the aorta, and we can get a full sense of where the widest margins of the aorta are in order to place the calipers and get a best evaluation of the true measurement. So the cylinder effect, some of the pitfalls of measuring the aorta in the long axis configuration, and remember the short axis orientation will be the best way to truly measure the aorta. This video clip emphasizes that the best measurements of the abdominal aortic lumen will be in the short axis orientation, but that we must make measurements from outer wall to outer wall. Notice this very large AAA, and we can see a large amount of thrombus coating the walls around the actual interior part of the lumen. And we could vastly underestimate the true diameter of the abdominal aortic aneurysm if all we measured was the lumen towards the middle. Thus, here we're correctly measuring, and notice that we're including the lumen plus the thrombus towards the outer part of the aneurysm, and we have the true diameter of the abdominal aortic aneurysm at an outstanding 8 by 8 centimeters as a AAA. So just remember, include outer wall to outer wall, and include the thrombus in your measurement of the abdominal aortic aneurysm. These are two video clips from a patient who presented with an abdominal aortic aneurysm and who was symptomatic with abdominal and back pain. We see two pictures taken in a short axis view, a B-mode or grayscale image to the left, and a color power Doppler image to the right. Let's take a closer look at the B-mode image to the left. What we can see there is the hyperechoic bone table defining the posterior aspect of the video clip, and on top of the bone, the spine, we see a large abdominal aortic aneurysm. Notice the muscular thick walls of the aneurysm. Looking at the image to the right, we can see an image with color power Doppler. Notice the turbulent flow within the lumen of this abdominal aortic aneurysm. Now we're going to measure the dimensions of the abdominal aortic aneurysm, and we're going to use the short axis configuration as we should for measurements to avoid the cylinder effect. And recall that we also want to include the thrombus within the measurements of the abdominal aortic aneurysm. So it's really outer wall to outer wall for the calipers. And here we can see the calipers placed in AP and lateral dimensions coming up with 4.8 by 4.9 centimeters, fulfilling the criteria of an aneurysm greater than 3 centimeters. Here's an interesting video clip showing a very large aortic aneurysm in short axis configuration. We'll begin by identifying the spine, that bright hyperechoic bone table towards the posterior aspect of the image here. That will be our landmark for identification of the aorta, which should sit directly anterior on the spine. Notice the small lumen of this abdominal aortic aneurysm and the multiple onion skin layers of thrombus surrounding the small lumen of the aneurysm. Now we could vastly underestimate the true dimensions of this aneurysm if all we looked at was the small lumen in the middle. Remember, we must include the multiple layers of thrombus to the outer walls. This is the same aneurysm in a long axis configuration. I have the probe positioned in a mid-sagittal type orientation with the probe marker towards the patient's head, superior to the left, inferior to the right. This is a finding that I like to characterize as the subway sandwich sign, and we see the loaves of bread, which are the thrombus, both anterior and posterior, surrounding the filling, which is the lumen, which goes courses down the middle part of this aneurysm. And we can see here with a small indicator arrow the large burden of clot anteriorly there, and also we can see the clot posteriorly as well. Notice it's only a small amount of lumen left in the middle of this aneurysm. In this video clip, we'll apply color power Doppler to number 1 to find that this is truly a vascular structure, and number 2, where are the limits of the true lumen in the midst of all the clot burden. We see short axis configuration to the left, and we can see the pulsations of blood in the innermost part where the true lumen comes surrounded by the clot. Now let's inspect the long axis view to the right, and again we can see the pulsations of blood with color power Doppler pulsing down the innermost part of the lumen of the abdominal aortic aneurysm that is flanked by a large burden of clot anteriorly and posteriorly in this patient. Finally, we're going to measure this abdominal aortic aneurysm, and at first I had a difficult time figuring out where to put the calipers, but we can see here that I decided to put the calipers down on that anterior wall where I thought the level of the onion skins ended, and that was the most anterior part of the abdominal aortic aneurysm. And we can trace it posteriorly to the level just above the spine. I've also applied the calipers laterally, and we have a measurement of 6.3 by 6.1 centimeters, a large aneurysm, but again underscoring the point that if all we measured was the lumen, we could vastly underestimate this abdominal aortic aneurysm. Here's another video clip showing a very large abdominal aortic aneurysm. This one has quite an interesting appearance. Here we see the spine, our posterior landmark, and what we see here is the lumen of the AAA. Notice the large amount of thrombus burden that's located there primarily anteriorly, clinging to the anterior wall of this large AAA. As we put color flow Doppler there, we can see the flow within the lumen of the abdominal aortic aneurysm and the lack of flow within the thrombus area towards the anterior aspect of this AAA. Taking the measurements of the abdominal aortic aneurysm in the short axis configuration, we notice here with the calipers down anterior, posterior, and including that large amount of thrombus located there anteriorly, as well as the calipers located in the lateral margin, coming across from the right to the left, we have measurements of 6.3 by 5.8 centimeters. So a very large AAA, much greater than 3 centimeters in dimensions. This is a video clip of a large abdominal aortic aneurysm that I like to categorize as a AAA snowstorm. We're looking at a short axis configuration with a probe marker over towards the patient's right side, and we see a very large AAA sitting on top of the spine, and notice that it almost has the appearance of snow falling within the inner part of the lumen of this abdominal aortic aneurysm. As I saw the patient in December in New York City when there was a snowstorm outside, and here it appears that there's a snowstorm inside this AAA, I came up with the term of AAA snowstorm. And we can see here that in a large abdominal aortic aneurysm, the flow of blood can be very turbulent, causing deposition of this blood onto the walls of the abdominal aorta, causing thrombus burden to occur. Next, we're going to inspect this large abdominal aortic aneurysm in the long axis configuration. I have the probe marker towards the patient's head, so superior to the left, inferior towards the right. And again, we see the turbulent flow of blood within the lumen of this AAA, and notice that it's depositing down thrombus onto the walls of the abdominal aortic aneurysm, and we can see the clot burden both anteriorly and posteriorly located on this very large AAA. But it's interesting here, we can almost see each heartbeat with the turbulence of blood swirling within the abdominal aortic aneurysm. To further show the turbulence of blood within the large abdominal aortic aneurysm, we'll apply power-colored Doppler to this image. And what we can see here is a swirling around in a chaotic circular motion of the blood within the very large AAA here. And we can see how this would set up for the formation of a large amount of thrombus to coat the walls of this very large abdominal aortic aneurysm. So a AAA snowstorm with power-colored Doppler. Here we're going to measure the dimensions of this very large abdominal aortic aneurysm. We're going to measure in the short axis configuration to get our best estimates of the size, and we're going to place those calipers to include the burden of clot thrombus coating the walls of the large AAA. So we have the calipers both AP and lateral, and we come up with measurements that are outstanding of 8.8 by 8.6 centimeters. So this was a patient who needed direct transfer to the operating room for fixation of this very large abdominal aortic aneurysm. Interestingly, even though the patient had this gigantic abdominal aortic aneurysm, he had stable hemodynamics, so the surgeons requested a CAT scan with IV contrast prior to going to the operating room. And here's the resulting confirmatory CAT scan. Notice the gigantic AAA that we can see here filling the abdominal cavity, and we can see that it's located directly on top of the spine. Notice here the true lumen, as shown by the blush of contrast in the innermost part of the AAA, and we can see again the large amount of clot burden coating the outer walls of this abdominal aortic aneurysm. Now, fortunately, this CAT scan confirms the lack of rupture of this very large AAA, but just recall the caveat that in a patient who has unstable vital signs and a very large AAA is found on bedside sonography, delaying for a CAT scan can be the difference between saving the patient and death. This video clip shows a very rare saccular aortic aneurysm that may be occasionally encountered in a busy EM practice. We're taking a long axis view of this AAA. What we have is the probe marker is towards the patient's head, superior to the left, inferior to the right. And we can see the aorta stretching out from left to right across the screen, and we see a little bump coming off the aorta anteriorly, making up that saccular aneurysm, the outpouching of the abdominal aortic aneurysm, coming off the anterior wall there. Interestingly enough, this patient presented with epigastric abdominal pain, and at first we thought she only had gastritis. When we actually put the calipers down and measured this abdominal aortic aneurysm, we can see here that the calipers come up with a measurement of 4.4 centimeters, fulfilling the criteria of a AAA greater than 3 centimeters. Now here I'm measuring in the long axis configuration, and while this can be a little bit dangerous in terms of underestimating the size, as we talked about in the cylinder effect, this saccular aneurysm was best appreciated in the long axis plane. So these measurements were actually pretty good and lined up with the confirmatory findings on CAT scan. Let's switch gears here and discuss aortic dissection, which may occasionally be seen on bedside sonography of the aorta. Aortic dissection has a very different pathophysiology from abdominal aortic aneurysm, as a AAA usually involves all layers of the abdominal aorta with a diffuse outpouching due to usually chronic hypertension. Aortic dissection differs from a AAA in that it involves a tear in the thoracic aortic vessel wall, with a subsequent development of a false lumen within the thoracic aorta and a subintimal hematoma which may extend from the thoracic aorta down to the abdominal aorta. Ultrasound may visualize the flap in the abdominal aorta on visualization of the aorta in the epigastric region, on those types of dissections which extend down distally. There's two main classifications for aortic dissection. The first one is the DeBakey classification. Type 1 DeBakey classification involves the ascending aorta, the aortic root, and the descending aorta. Thus, just remember that type 1 gets it all. Type 2 differs from a type 1 in that it involves only the ascending aorta. Now, this is a very crucial part of the aorta as it can involve the aortic root and the aortic valve, causing aortic regurgitation and may also cause a pericardial effusion. Type 3 involves the descending aorta distal to the left subclavian artery. We can subdivide type 3 DeBakey classification aortic dissections into a type 3A, which involves a descending aorta but stops above the level of the diaphragm, and a type 3B, which involves a descending aorta but extends below the diaphragm and can be picked up on sonography of the abdominal aorta below the diaphragm. The other widely used classification for aortic dissections is known as the Stanford classification. And it's an easier one to remember as a Stanford type A dissection only involves the ascending aorta. A Stanford type B dissection, conversely, involves the descending aorta. Thus, it's an easier system to remember and now more widely used when describing aortic dissections. This video clip is from a patient who presented with chest and abdominal pain that radiated to his back. And as we looked into the epigastric region in a short axis configuration, we can see the abdominal aorta above the spine. Looking at the dimensions of the abdominal aorta, we notice that they're enlarged, consistent with an aneurysm. But we also note another finding, and that is the presence of a flap directly in the middle of this abdominal aorta, consistent with aortic dissection. So this would be a Stanford Class B or a DeBakey Class 3B. Enlarging the ultrasound image from the last patient, we get a better look now at this aortic dissection, and we can clearly see the flap extending down the middle of the aorta, and we see the true lumen of the aorta towards the right, and the false lumen of the aorta over towards the left. So clearly making the diagnosis of an aortic dissection extending down into the abdominal cavity from the thoracic cavity. This video clip shows an aortic dissection in a long axis configuration. Marker dot towards the head, so superior to the left, inferior to the right. We have the probe positioned in a mid-sagittal orientation, so we see the liver anteriorly and the aorta posterior. Notice the flap moving all the way down the aortic lumen, and we can see here that the true lumen of this aortic dissection would be anterior to the flap and the false lumen posterior. Now remember here that we would need to get a CAT scan to further evaluate this patient of both the chest in addition to the abdomen, and it's a different team of surgeons that we would call. This would be the chest surgeons as opposed to the vascular surgeons that would usually handle a AAA. This video clip was taken from a hypotensive elderly patient who presented to the emergency department with abdominal and back pain. And here we see the probe placed in the epigastric region in a short axis configuration. Notice the wide dimensions of the aorta consistent with an abdominal aortic aneurysm. Looking at this aneurysm in long axis view, we see another finding here. And notice that this aneurysm is going to originate in the thoracic cavity, and we can see here that it moves past the diaphragm distally to involve the abdominal aorta. So this is not a simple abdominal aortic aneurysm or AAA. This is a thoracic aortic aneurysm that descends past the diaphragm into the abdominal aorta. Here's the accompanying CAT scan from that same patient, and interestingly enough, now we can further delineate what's going on here, and we see a very large thoracic aortic aneurysm that involves both the ascending aorta and the descending aorta, and we notice here the presence of a large amount of hemorrhage. Interestingly enough, this hemorrhage is not into the usual left pleural cavity, it's extending over into the right pleural cavity. So this patient went directly to the operating room for stenting and did survive. Let's now discuss rupture of an abdominal aortic aneurysm. The majority of AAAs will rupture into the retroperitoneal space, an area that's difficult to see with sonography. Unfortunately, it's a minority of those that will rupture into the peritoneal space where we can actually see them easily with bedside sonography. If a AAA does rupture into the retroperitoneal space, it can compress retroperitoneal structures such as the ureter and may be mimicking a kidney stone in an older patient. Interestingly enough, the FAST exam will be negative in retroperitoneal rupture as the retroperitoneal cavity is not specifically evaluated by the FAST exam. Because of these limitations of sonography for seeing a rupturing AAA into the retroperitoneal space, in a patient who has unstable vital signs, you must first search for an abdominal aortic aneurysm on bedside ultrasound. If a AAA is found and the patient is hypotensive, assume rupture into the retroperitoneal cavity and mobilize the patient towards the operating room, deferring unnecessary delay in the ED, such as waiting for a CAT scan. However, in a patient with stable vital signs in which a AAA is seen, a CAT scan is indicated to look closer at that retroperitoneal area for rupture of an abdominal aortic aneurysm. Here's a rare video case of a patient who presented with acute abdominal pain, and on palpation of his abdomen I thought I could feel a pulsatile mass. So I brought the ultrasound machine to the bedside and took a look. And what you can see here is, towards the posterior aspect of the image, a large aortic aneurysm, and anteriorly we see a large hematoma extending into the peritoneal cavity. So this was a very rare type of AAA rupture into the peritoneal cavity as opposed to into the retroperitoneal space. In the next clip, we're going to apply color power Doppler to this image, and what we can see is the pulsations of blood within the very large abdominal aortic aneurysm that we see sitting posteriorly on top of the spine. And notice again, coming anterior to the AAA, the large amount of hematoma that's extending almost all the way to the abdominal wall. A very interesting case, as apparently this hematoma was contained by a flap of omentum that had sealed the amount of hematoma that was bleeding. And interestingly enough, this patient actually had stable hemodynamics in the emergency department. Very, very strange and unusual case. Due to the fact that the patient had stable hemodynamics, we consulted vascular surgery and obtained a CAT scan. What we see here is a CAT scan confirming an intraperitoneal location of a ruptured abdominal aortic aneurysm. And we see the AAA towards the posterior aspect of the image on top of the spine, and note the large amount of hematoma coming anteriorly into the peritoneal cavity off the ruptured AAA. Fortunately, this patient was able to be taken to the operating room where he was stented and survived to do well. This video clip shows another example of a ruptured abdominal aortic aneurysm, this time into the usual retroperitoneal location. We see the IVC and aorta on top of the spine in the B-mode or grayscale image towards the left, and we see a hematoma located just to the right of the aorta, extending backwards into the retroperitoneal space. Notice as we put color power Doppler towards the right, we can see pulsations of blood within the aorta, and notice the hematoma surrounding the aorta to the right and in the retroperitoneal space. So this is the more common location for a rupture of a AAA, and this can be difficult to diagnose using bedside sonography. For these reasons, it's best to use your clinical indicators in deciding if the patient has a ruptured AAA that's going into the retroperitoneal space. If the patient is unstable, you need to advocate to move the patient directly to the operating room for stenting and/or open repair. And if the patient has stable hemodynamics, it's time to get a stat vascular surgery consult and move the patient quickly to a CAT scan to further delineate where is the area of the rupture and how the best approach to the AAA repair would be for the vascular surgeon. A new issue for emergency physicians caring for patients who have undergone repair of a AAA in the past is that they may represent to the ED with complications of the repair. In the past, open repair of a AAA with placement of a graft was more common. Nowadays, what's becoming more in vogue is closed repair with endovascular stenting. However, in patients who have undergone either of these procedures, they may represent to the ED with slow or fast blood leakage from the site of the repair. Also, inflammation around the repair can occur, causing an inflammatory area around the graft. Thus, in these patients, it's best to lower your threshold for CAT scan imaging to further delineate what's going on with the area of the repair, and also to call for a vascular surgery consultation to help in your disposition of the patient. This next video clip was taken from a patient who represented to the ED 1 month after placement of an intravascular graft for repair of a AAA. And as we scan through the area that was painful in her lower abdomen, we can see there the graft well delineated on top of the spine. But notice anterior to the graft a large amount of inflammation and thrombus surrounding the graft. And as we look through that area, scanning back and forth through that area of inflammation and thrombus, what we can see is that there's darker and lighter areas. Interestingly enough, a CAT scan revealed that the darker areas, the hypoechoic areas, were areas of fresh blood leakage into the thrombus around the graft. And she also had those lighter areas which were inflammation that had occurred around the graft. So the patient was readmitted to the hospital for reoperation. Let's close out this module by talking about some pitfalls and useful hints for imaging of the aorta on bedside sonography. The abdominal aorta may at times be difficult to see, secondary to bowel gas, so press the transducer firmly down towards the spine to displace the bowel gas and get a good look at that aorta on top of the spine. If the patient is obese, switch to a lower frequency to increase penetration and get a better look at deeper structures within the abdomen, such as the aorta. You can also use color Doppler to better identify vessels to make sure that you're looking at the aorta as opposed to another structure in the abdomen. And just be careful because at times the spine may be mistaken for a AAA using B mode or grayscale sonography. The first pitfall that I want to show in video is the mistaking of the spine for an abdominal aortic aneurysm. And here we can see as I scan through the area of the abdomen using B mode or grayscale imaging that the spine comes into focus posteriorly within this video clip. Notice that it has a circular appearance that at first glance could be construed as a vascular structure such as the aorta, but if we look closer we can see that the aorta is located anterior to the spine. Also we can see the IVC to the right of the aorta. But just be careful because at times the spine can mimic a vascular structure such as an aorta, so look closely for structures anterior to the spine, which in fact would be the abdominal aorta. And also we could use color power Doppler to help delineate the two structures. This ultrasound image shows a rare pitfall on imaging of the aorta, and at first glance the large structure that's seen in the anterior part of the image here could be construed as a large abdominal aortic aneurysm, but close attention to the details of where is the spine will help in differentiating the structure. So let's take a look first at the spine, which we can see as located towards the posterior aspect of this image, and we can see the aorta located anterior to the spine. Notice there that the cyst here, in fact a large mesenteric cyst, sits anterior to the aorta. So this was interesting image, but one that was initially construed as an abdominal aortic aneurysm, but on closer inspection was seen as a large mesenteric cyst. Also, on application of color power Doppler, the cyst did not light up, and the abdominal aorta posterior to the cyst had color flow pulsations. This CAT scan shows another potential mimic of an abdominal aortic aneurysm. I don't actually have the ultrasound image of this, but I think this CAT scan makes some interesting and important points. Here we see the aorta located on top of the spine and the branch point of the superior mesenteric artery coming off the aorta anteriorly. Notice here we see a large area that's very irregular anterior to the branch point of the superior mesenteric artery. Interestingly enough, this was a large superior mesenteric artery aneurysm. This is another slice from that patient with the superior mesenteric artery aneurysm. Again, we see the aorta well delineated on top of the spine, and anteriorly we see a very large SMA aneurysm. Now the truth of the matter is that this would be treated just the same as an abdominal aortic aneurysm by a vascular surgeon needing endovascular stenting and or open repair. However, on ultrasound imaging, close attention to the details of the spine and the aorta in regard to this SMA aneurysm would help sort out that this was in fact not an abdominal aortic aneurysm, and this was a branch point aneurysm of the superior mesenteric artery. In conclusion, thanks for tuning in to the Soundbites module covering part 2 of bedside ultrasound of the aorta. Hopefully now you understand the definition of and anatomy found on bedside ultrasound imaging of an abdominal aortic aneurysm. And now you can use bedside sonography as a rapid diagnostic tool in those patients who present with unstable hemodynamics and a rupturing AAA, facilitating timely operative management and minimizing the delay to triage mobilization of this patient towards the operating room to save a life. So in conclusion, I hope to see you back as Soundbites continues and we move on to discuss other topics within the realm of bedside sonography.